Welcome, everybody. This is the January 28th, 2021 Renal Biopsy Conference from Rush University Medical Center. We have a great case today. Dr. Whittier is going to be presenting. Today's activity code is 481294. This is being recorded and it'll be available on YouTube in a week or two. Please subscribe to our channel. As usual, we have nothing to disclose and patients have been de-identified. I will let you know now that we're not having a conference next week, next Thursday, but we will have one the Sunday after. That's February 7th. It'll be at 10 a.m. It's going to be part of the GlomCon program. So if you subscribe to GlomCon, you'll get an announcement, and we will also send an announcement out. But for those that aren't on our mailing list, just go to glomcon.com and you'll be able to find, it's GLOMCON, you'll be able to find the information. But it'll be 10 a.m. Central Time on February 7th. It'll be through their website, and they'll and then we're gonna give it a trial there. We'd like to get as many people as possible on that and see if we can increase our international audience a little bit, since this time slot is tough for the international people. So let's get started. Let's move up to the case, and Dr. Whittier, this is your case. I think Dr. Balut is going to read it for us.
Yep, so patient is a 60-year-old Black woman with significant past medical history of hypertension, hypothyroidism, OA, and lung adenocarcinoma. She was treated with resection only, no chemo or radiation therapy. She's presenting for evaluation of hip pain, leg swelling, and proteinuria. She had initially presented to her PCP for pre-op evaluation for hip replacement. Her complaints were significant for hip pain that limited her walking and activities at work. During that visit, she also told her PCP about a 1-week history of bilateral lower extremity swelling. About 1 month prior to presentation, she was started on high-dose naproxen by her orthopedic surgeon for hip pain that was refractory to Tylenol. Her UA was notable for 3+ protein by dipstick as well as some hematuria. Her UPC showed 11 grams per gram of proteinuria. Her serum creatinine was normal at 0.54. Her serum albumin was low at 2 grams per deciliter, which was consistent with nephrotic syndrome. In 2015, her prior UA had no protein by dipstick, and about 6 months prior to this current presentation, her UA also just had trace protein but no blood. In terms of her past medical history, she had high blood pressure, hypothyroidism, osteoarthritis, and lung adenocarcinoma that was treated with resection only. In terms of her past surgical history, she had a history of a thyroidectomy in the 1980s, and she had a total hip arthroplasty about 5 years prior, as well as a left upper lung lobectomy as part of her treatment for the lung adenocarcinoma about 4 years ago. She did not smoke, and she had no significant drug or alcohol use. Family history was unremarkable for any renal disease. On review of systems, really only notable for the bilateral lower extremity swelling, no fevers, no chills, no chest pain, no dyspnea, and no GI symptoms or loss of appetite. She had gained about 7 pounds in the past month or so. No allergies. In terms of medications, she was just on the levothyroxine, the amlodipine, and the cholecalciferol, as well as the naproxen, which had since been discontinued by the time that we saw her. On physical exam, her vitals were stable. She was normotensive. She had a normal pulse and a normal respiratory rate. Her BMI was only 18, and she was sitting well on room air. Physical exam, she was resting comfortably. She had clear lungs bilaterally, normal cardiac exam. Only remarkable thing really was the bilateral lower extremity edema, and it was about +1 pitting in both extremities. No rashes on exam. In terms of her labs, her sodium was 140, her potassium was 4.8, her chloride was 105, her bicarb was 26, BUN of 17, creatinine of 0.54. Her glucose was 90, and her total protein was 7.8 with an albumin of 1.9. Calcium was 8.2, and her LFTs were within normal. The remainder of the LFTs were within normal limits. On CBC, she had a white count of 3.6 with a normal differential. Hemoglobin was 9 with an MCV of 103, and platelets were 300,000. Lipid panel was unremarkable. Cholesterol was okay at 165, triglycerides of 85, HDL 53, and LDL 94. For her serological workup, she had an ANA that was negative, an anti-double-stranded DNA that was negative, mildly low C3 at 78, a normal C4 at 39, negative rheumatoid factor, negative hepatitis panel, HIV. The PLA2R antibody was pending at the time of the biopsy. On her serum immunofixation, she had an IgA monoclonal kappa. Serum-free kappa was elevated at 84. Serum-free lambda was low at 0.42, just mildly. The ratio was elevated at 211. Her urinalysis had a specific gravity of 1.041, a pH of 6.6, with a 4+ protein by dipstick, +1 blood, 22 RBCs, and 6 WBCs. Her UPC had about 11 grams per gram. On urine immunofixation, she had a monoclonal IgA kappa. Total urine protein was about 12 grams per day with 54% albumin. On renal ultrasound, both her kidneys were normal in size and echogenicity. The right kidney was 12.4 centimeters in length and the left kidney was 11 centimeters. There was no stones or hydronephrosis. A percutaneous renal biopsy was performed to further evaluate.
All right. Anybody have any questions? By the way, we've got the microphones open for the faculty. Put your questions in the chat board and we will address them.
So any history of any cardiac disease, or did she have an echocardiogram to see if she had any cardiac dysfunction or constrictive pericardial disease?
She had not had a cardiac exam by the time we saw her. The last one had been done in 2012.
And that was okay?
That was okay.
All right.
All right. Dr. Baxi, you want to unmute yourself and let us know what your thoughts are in this case?
Yeah, perfect. So yeah, it's ultimately this patient is presenting with, nephrotic syndrome, and as you look through it, I mean, it's a little kind of classic of, normal tension. The patient's not hypertensive, normal serum creatinine, and has, hypoalbuminemia, and had about 11 grams of urine protein on collection, which was almost 60% albumin. So there's a lot, it's consistent with the nephrotic syndrome. And as you go through it, it's interesting because there's a lot of different things it could be. But, when I see nephrotic syndrome, I tend to look at the onset because that sometimes can give us clues. So just starting with the HPI and looking at the onset, it appears to be a little quite sudden. And sometimes that's subjective, and maybe it had been going on for longer, but for taking it what it is, the patient said it was a 1-week history of bilateral swelling and all of a sudden had an increase of weight within a month of 7 pounds. So to me, that seems quite sudden. And when you tie that together with her recent use of NSAIDs, minimal change becomes on my differential, and it becomes high given that onset and that use. Now, I also look at the age when I think about sudden onset and with minimal change, having the bimodal presentation. She's 60, maybe not as old as you would see with some kind of idiopathic minimal change disease, but we do have the NSAID use. So that's on there. Other part of her HPI and medical history is the cancer, and she's having this hip pain, which was why she was taking the NSAIDs. Now, she does have a history of, it looks like osteoarthritis, but she also has a history of adenocarcinoma. And there's always a concern that she may have another malignancy. And so membranous presenting as nephrotic syndrome is also on my differential. What would support that? Maybe this has been going on a little longer than we think. There's a little bit of hematuria, which it would be more seen in membranous, although minimal change, you can have some hematuria, but you think of more of that in, minimal change, you can have it, but I think more of in membranous, you have hematuria. So that's definitely on something to consider too. And so as we're going through the exam, again, not hypertensive, serum creatinine is normal. Sometimes membranous can kind of linger around before it really you start to see renal insufficiency. And then we get to two interesting things. One that was mentioned was the lipid panel on the chat. And yeah, you would expect, for a kind of minimal change, especially for the triglycerides and cholesterol, but really much higher. And these are pretty unremarkable, which is interesting. But, that's one thing. And then you go to the serologies. The serologies is where you're given another factor of what could be going on here. And that's this patient does have a monoclonal IgA, kappa. Now, the kappa is pretty high and the ratio is quite elevated. And this patient had normal kidney function, but 211 is way outside the norms of any type of renal insufficiency. So you start thinking of a paraprotein-related lesion. Now, these patients with paraprotein-related lesions shouldn't really present with sudden onset nephrotic syndrome. We typically think of more of a CAS nephropathy and AKI presenting in these patients. Now, this patient has normal kidney function and, again, 12 grams of protein, which is primary albumin. So it'd be unusual to have all of a sudden a paraprotein such as amyloid or light chain deposition disease present like this, but now you have to consider it. And that's why this biopsy will be quite interesting to see. In terms of the kappa, I typically think of that as more of a light chain deposition disorder and not really amyloid, which is more of a lambda. But again, no cardiac history and the sudden onset makes me think of this less, but we'll see what the biopsy ultimately shows. And then finally, looking at the ultrasound, if you're thinking of paraprotein and other type of paraprotein-related lesions, you're thinking about maybe slightly larger kidneys. Now, these kidneys are, 11 and 12, nothing out of the realm of normal, but so that doesn't help us one way or the other. So putting that all together, and then finally, my one other differential I would put in here is looking back to her demographics is she's Black and FSGS. Tip lesions can present with sudden onset nephrotic syndrome. So, that could be another potential here. And so those are my 4 top diagnoses. If I had to choose number 1, I'm going to go with the timeline of naproxen being started and the sudden onset and putting weight on that, even though the triglycerides and the cholesterol panel doesn't fit. I'm going to go with minimal change 1. I'll go with a membranous 2, and then a tip FSGS lesion 3, and then finally you have to consider a paraprotein-related lesion. Just the onset doesn't seem like that, but I'll put a paraprotein-related lesion 4. And with the kappa, I would think of more of a light chain deposition. I don't think we'll see CAS nephropathy based on the renal function.
Boy, I'm gonna jump in right now before someone else takes over. I'm gonna suggest that those kidneys are actually large. I mean, a 12.4 centimeter kidney on the right is a pretty good sized kidney, especially in a 60-year-old, and even 11 centimeter. Usually they're around 10 centimeters, especially in women. And as we get older, they actually start to get smaller again, but 12 for sure is on the large side. And it's interesting that the right kidney is bigger than the left when usually it's the other way around. And I agree with everything you're saying, Pravir, but I have to admit, that ratio of 211, if it's a paraprotein related renal lesion for me has got to be high on the list. And as you suggest, kappa is usually associated with light chain disease, lambda more or less with amyloid, but it's not 100%. It's like 60, 70% each of those. So that it still could be amyloid or a light chain deposition disease for that matter, which could have very much a similar kind of presentation as amyloid does. So I'm jumping in, I know, but I would flip the order around and suggest that a paraprotein related renal disease is high on the list. And I still think even though half of this is albumin, that means that you've got almost 6-7 grams of something else, which could easily be the light chains, given the fact that the ratio is extremely high. And, for minimal change disease, a cholesterol 165, it's pretty low. Anyway, I just want to, that's my only comment.
Steve, how do you feel about, at least with non-steroidals, you often see some AKI and interstitial nephritis. Do you know what % of these patients would just have a picture of minimal change disease without the interstitial nephritis?
You know what? In our experience, it was about half would have. I'm sorry, without interstitial disease without.
No,
Or-
nephrotic syndrome without any evidence of interstitial disease.
It was about
Pure-
half.
Pure minimal change.
It was about half of the
'Cause
people.
I suppose it's difficult to tell then if you have just, I mean, people take nonsteroidals all the time. If you have interstitial nephritis and AKI with it, it probably points much more to a nonsteroidal induced. But if you just have minimal change disease, it's possible that you have idiopathic minimal change disease and you take nonsteroidals.
That's true. Again, I still would have expected the cholesterol to be a heck of a lot higher even with that.
Mm-hmm.
I mean, I would have expected, I mean, this is 165. This isn't bad at all. The HDL is only 50. I'm sorry, the LDL is only 94. You know, anything's possible, but I think for minimal change disease, even due to NSAIDs, that would be somewhat unusual.
Mm-hmm. Dr. Glassick, I see we have, you're in the audience. Pravir, can you unmute him?
Yeah, I'm unmuted
There we
now.
go.
Can you hear me?
Okay, great. Yes, we
Yes.
can. So I have a couple directed questions to you, right? You had mentioned this notion of the cholesterol, and we've talked about this several times, and nobody seems to know the answer. And maybe there is an answer, maybe there isn't. But what is it about minimal change that has such a high cholesterol? It seems to be out of proportion with in any other lesion. You know, do you have an answer for that?
Well, I used to think that it was related to the changes in protein synthesis by the liver, but as a result of a recent article in JASN, we have to now include the PSCK9 activity in the serum because the collecting duct in proteinuric patients seems to make excessive amounts of this protein that promotes the development of hypercholesterolemia. So I think the mechanisms for hypercholesterolemia and nephrotic syndrome now are undergoing an interesting change, and it may be that the kidney is more important than the liver. The point I made in my little chat note was that normal cholesterolemic nephrotic syndrome is a real entity. And among the patients who have this presentation, amyloidosis and lupus are the two predominant lesions seen. And I don't know why. These two causes of nephrotic syndrome, amyloidosis and lupus, tend to have lower or normal cholesterol levels despite severe nephrotic syndrome.
Well, would you agree that, I mean, if I had 10 grams of protein with say, membranous and 10 grams of protein, same patient with minimal change, would you agree that the cholesterol is often higher in that patient with minimal change? Because that's kind of our feeling.
Yes, I agree.
And so what is it about minimal change, the pathophysiology of this lipid abnormality that would, do we have any idea why it would be higher?
Well, I think we need to now look at the PSCK9 levels in these patients.
Yeah,
That hasn't been done to my knowledge, but it may well be that very high levels of PSK9 is a biomarker of minimal change disease and accounts for the marked increase in LDL synthesis seen in these diseases.
Yeah, that's really interesting. I didn't know any of that. What is your, let me ask you another question. What is your diagnosis here, and how much of a role do you play in this ratio of capital to lambda? At what point do you,
Well,
I mean,
think
monoclonal gammopathies are common, but at some level ratio might trump everything else. So I'm sorry.
Well, I think in a patient with a hemoglobin of 9, marked proteinuria, and a kappa lambda ratio of this magnitude, the first diagnosis is multiple myeloma. And I don't know what the pain in her hip is, but I sure would like to see what the x-rays show, as she may have an osteolytic lesion.
And how does the kappa influence you? Does it influence you a lot? Is that pointing more towards a myeloma?
A lot.
Okay. You know, Ed Lewis used to say when patients with amyloidosis presented with nephrotic syndrome, they always had renal insufficiency. But I don't know how true that is.
That's not true. I have seen a number of patients. I mean, I respect Ed, and nearly always he's correct. But in making a statement that amyloidosis of the kidney with nephrotic syndrome must have impaired kidney function, I can tell you I've seen a lot of cases in which amyloidosis was present and the lesion resembled minimal change disease. That is, the relationship between the amount of amyloid in the kidney and the degree of nephrotic syndrome isn't a direct one.
Yeah.
So I don't think you can make a judgment here. That's my opinion. I don't know. I'd certainly like to hear from Steve and Roger on this, but that's my experience.
No, that point comes up constantly, and Ed does make that point as well, is that the Congo Red positivity is usually kind of what people are generally talking about. And I don't know if that's what you're alluding to, but the Congo Red positivity, which is what we gauge them as having, you know, what is how we gauge they have amyloid. It does not necessarily correlate it with the severe, with the level of proteinuria, which I think gets back to this whole issue of, you know, the beta pleated sheets, the microfibrils that are formed. It's not them alone that are nephrotoxic. It's the precursors, if you will, in the case of light chains, you know, the cleaved light chains that may as well, before they even become microtubules or fibrils, they themselves, those precursors may be as toxic as the actual Congo Red positive microfibril that we look at. So the correlation of Congo Red positivity doesn't tell the whole story. It's the precursor protein that may be as important as anything.
I'm not a pathologist, Steve, as you know, but there is a tendency for pathologists to use very thin sections in their examination of renal biopsy material. And in amyloidosis, it's important to use thick sections because the amount of amyloid deposited can be so scanty that sometimes you don't detect it with Congo Red, or at least it's so slightly increased over background. Of course, EM may be the sort of definitive tool here since it is much more sensitive than the Congo Red.
Good point.
All right, let's move on. I think Dr. Baxi has a poll. We're going to give a shot here and see what people want to vote. So co-hosts don't vote, and I think that means Dr. Glassick don't vote because I think that'll mess up the poll because you're a co-host now. So just people that are not co-hosts. Getting a nice response. That's great.
Give it a couple more seconds here.
Yeah, there's a little bit of lag. That's a nice response. Thanks for responding, everybody. By the way, we have a new biopsy conference record at 54. I think Dr. Glassick brought him in.
We'll have to advertise in the future that Dr. Glassick's joining us. That'll probably increase it even more.
Well, he set the GlomCon record last week, so it's no surprise.
You can see what we're seeing here. So the majority said paraprotein-related lesion, 84%. Minimal change was number 2, 9, membranous 6, and no one bought on the FSGS. But let's see what the biopsy, I guess, spin the wheel next?
Yeah, let's spin the wheel.
Spin the wheel.
Okay.
All right. Wow, the wheel has no sound. I like the clicking usually. Uh-oh.
Faraz? Somehow the wheel likes you.
All right, Faraz, give me a second here.
Okay, so you've got one core here. It's a trichrome stain, low power. I can see, you know, the tubules here look pretty well packed together. There's multiple glomeruli in this section. And it looks like it's all cortex. I don't really see any fibrosis. I would say, 0, maybe like 5% if you count some of the couple spots.
Those are probably just glomeruli. Yeah, there's no significant fibrosis here. Looks like a good preserved kidney.
Yeah, and that correlates with her creatinine and GFR. A little higher power. It's still low power. H&E. We've got multiple glomeruli here, and the tubules here. They look abnormal.
Well,
they look in this.
So this is a medium to low power. There's a history of heavy high-dose NSAID use. So do you see anything that looks like interstitial nephritis?
Yeah, I mean, we see, some cellular infiltrate in the interstitium.
So those are actually just distal tubules. There's no infiltrate here.
Oh, okay.
Yeah, there's glomeruli. You could see the infiltrate would be spreading the tubules apart. You'd see some edema. We see none of that here.
Okay.
Yeah. And then now we'll see the glomeruli at a higher power.
Okay, so this is higher power, still H&E. The glomeruli, there's some, it looks like there's some mesangial expansion in a couple areas. It doesn't look hypercellular, maybe like a little bit here. I don't know if you can see my mouse, but at like 4 o'clock, there's some more cells than I would expect in the mesangial area. The capillary loops look nice and open. And then looking outside in the interstitium and at the tubules, the tubules here, it looks like there's what could be like protein reabsorption droplets.
Wait till you get the PAS for that.
Okay.
Yeah. So for us, going back again to the glomerulus,
Yeah.
the expansion, does it look symmetrical throughout, or in uniform, or asymmetrical?
To me, it looks asymmetrical.
Yeah, right in that area, right above the middle.
Yeah.
It's quite markedly expanded compared to other areas. Yeah, there it is. Yeah.
And it's acellular, right? There's no lot of nuclei in that. That's just expanded mesangium.
Yeah.
Yeah, without hypercellularity.
Yeah.
Okay, good. Yeah, let's see the next slide.
Okay, another high power H&E stain. We've got one glom in the middle. Again, open capillary loops. I see a couple focal areas of mesangial expansion without hypercellularity. And then looking outside at the tubules, there's some debris in the tubule here. And, parts of the epithelium looks thinned out. So maybe there's some ATN going on.
That may just be processing, if it doesn't get into formalin right away.
Sorry.
Yeah.
Okay.
Yeah, there's some preservation artifact in the tubules.
Okay. And then here we have a high power PAS. And looking at the glomerulus again, open capillary loops, couple areas of mesangial expansion up at like 12 o'clock, right where the mouse is. And then maybe again at like 5 o'clock at the bottom.
So compare the intensity of the stain to other mesangial areas. What do you notice?
It's light.
Mm-hmm. Yeah, we call that weakly PAS positive. Yeah.
Gotcha. Yeah, weekly PAS positive.
Yeah. And in fact, there at 12 o'clock, you even see kind of how it's extending out, yeah, into the capillary loop. Yeah, yeah.
Okay. And then looking at the tubules outside, some of the like luminal side of the epithelia look dark. Are those the protein reabsorption droplets or?
Yes, there are some little ones, not as striking as other cases.
Okay.
But in the tubule right above the arrow, there might be a little more prominent. Yeah.
Okay.
Ross, I think it is, considering a differential diagnosis was, cast nephropathy. Is there any evidence of cast nephropathy that we've seen so far?
You would see like expansion of the tubular cells, I think, like enlargement.
You would see proteinaceous casts inside the tubules that are
inside the tubules too.
They look fractured.
Yeah, and I don't see that.
Okay.
Okay.
That's right. Yeah, yeah. There's no evidence of myeloma cast nephropathy.
High power PAS again. So many people trying to enter. And then in this glom, we've got open capillary loops. There's at about 5 o'clock down here. There's an area of mesangial expansion that's weekly PAS positive. Same thing, a larger area at like 11 o'clock. And then outside in the tubules, you've got good brush border in the couple tubules right below the glom. And I don't see any like interstitial edema or fibrosis. The tubules are well packed together.
Okay, good.
We're looking at the capillary walls in the basement membrane for any breaks, spikes, or holes.
And what is the stain?
Jones stain.
Yep.
High power. I don't see any spikes. And I mean, we don't have any like necrotic lesions, but like, there's an area that looks like there's a break, but it might just be the cut.
Yeah, yeah. It probably the GBN's probably just diving back.
Yeah.
Yeah. No, there's really no significant pathology on this.
Yeah, I just see some areas of mesangial expansion that we've been seeing.
Yeah. And then to the left, there's some good protein reabsorption droplets. Yeah.
Okay. Yeah. Alrighty. And then this is the Congo Red Stain, it looks like. And it looks pretty positive in the mesangial areas and the
And anywhere else or just mesangial in the glomerulus?
There are a couple places where it looks like it's in the capillary walls.
Yeah, especially
too.
over at 9 o'clock. Yeah.
Yeah, that's where I'm looking.
Yeah.
Is that it?
Predominantly mesangial and then segmental capillary wall involvement.
Is some of this in the interstitium? Because some of it looks like it's outside the tubules.
Right. Yeah. Over like 9 o'clock. Yeah.
Well, even far left there. I mean, there's a bunch of stuff that looks like it's outside the tubules.
Yeah. In fact, yeah, we'll have the same glomerulus under polarized light, I think, on the next few slides, so we could.
This is a really impressive amount compared to what we saw in light.
Yeah.
Yeah, it's too bad we didn't talk about. I mean, never mind.
Oh, sorry. So yeah, here we have it under polarized light, and you can see it, in focal areas, but pretty spread out throughout the glomerulus, and even a little bit outside in the tubules.
All right, David, you know what I'm going to ask exactly. So if you change the orientation of the Nyquil prisons, based on the way in which the Congo Red fits into the beta pleated sheet, you'll have a completely 90-degree change in the or 180-degree change in the orientation. And so here it's going one direction, and when you change it back, it goes perpendicular. I mean, it's pretty cool. Now, what I was going to bring up is before we got into the Congo Red, mesangial expansion, doesn't necessarily rule out light chain deposition disease, because it can be mesangial nodular as well, and it's the fluorescence or the Congo Red which will make the difference, which will determine the difference. And this is pretty impressive. Before we get to the fluorescence, let me just ask you something, David, and actually Dr. Glassick as well. When I was in training, they used to help distinguish. Now, in this case, given the light chain in the serology, it's kind of a no-brainer. But the whole issue of determining secondary amyloid from AL amyloid, you'd use potassium permanganate, and if it was secondary, the Congo Red negativity would go away, and if it were primary, it would remain. David, I assume no one does that anymore.
Right. Well, I mean, I remember in a case at least 10 years ago, there was one older lab technician that knew that technique, and we did do it on one case. And then now there's a high turnover in the lab. All the technicians are probably in their 20s or 30s. Nobody has been trained to do that anymore. Yeah,
I mean, once you get the serology back, a lot of times the pathologist might not have any of this other information, or as they talk about paraprotein-related renal diseases, many of them you back into. In other words, it's the biopsy that makes the diagnosis, not the serologic evaluation, because not everybody gets this kind of a thorough evaluation. But anyway, it's just one of those little tidbits that probably never comes up on a test anymore. This is pretty impressive, though. There's this is pretty strong Congo Red.
One of those tidbits that only an older nephrologist would
well, there you go. But if it happens to come up on the boards, they'll be glad that it was brought up.
Yeah. I'm sure potassium permanganate will come up on the boards, but the new movement is to do mass spec on these to tell exactly what they are. But I don't know.
Yeah, that's because everybody has a mass spec in their pathology lab. Do we have one, David?
No.
Yeah, there you go. Send them to the Mayo Clinic.
Yes.
Well, I'm not sure you would need it in a case like this, but there's certainly a lot of other amyloids out there that you might need to distinguish if it's not light chain restricted.
Yeah, I would say 90% of the amyloid we could diagnose in our lab between the fluorescence, and then we have an immunostain for secondary amyloid. There's an immunostain for transthyretin.
Yeah.
But all the other 30 newer types, that ALEC2, all those other ones, have to be done by mass spectroscopy.
Fibrinogen A alpha, yeah.
I think that's a really good point, because Helmut Reinke is a strong advocate of mass spec, for evaluating these. But you're right. I mean, there are pretty good immunohistochemical stains. I don't know that you'd have to go to the next level, but he felt pretty strongly that anybody who's Congo Red positive, you just go directly to that. Next slide.
And then we've got immunofluorescence staining, positive for kappa, negative for lambda. And again, it's mostly in the mesangium, but wrapping around a couple loops. So some of it's in the capillary walls as well.
Yeah, so what does this tell you about the subtype of amyloid?
So this would be AL
Yes.
amyloid.
Yep.
It's a kappa light chain.
Yep.
And then we've got EM.
So where do you think you are on this, Roz? Where's the urinary space?
So the urinary space is at the bottom left at like 7 o'clock-ish.
And then where's the podocyte?
The podocyte is up at like 10 o'clock.
Yeah. And then what's next to that? To the right of that is what?
The GBM.
Yep.
And then the subepithelial space and the endothelium.
Yeah, and then what's all that stuff to the right?
So that they look like the fibrils that you get in like amyloid.
Or you got better eyes than I do, but I am sure you're right. It's some mass.
You can see it like rolling around. I'm sorry.
No, that's all right. It's a massive amount of some material, right?
Yeah.
I think it's grainy. I think it's grainy enough that you can kind of sense a substructure, especially since amyloid is so randomly, haystack driven. I can get the sense that that's on this power, but we'll see obviously in higher power. Bingo.
There we go. So yeah, you've got, this is all in the mesangial space. And these are supposed to be, I believe, 10 to 15 nanometers.
Well, first describe them. I mean, we have organized deposits of what? What's the key term?
The fibrils?
Fibrils, yep.
Yeah.
Yeah.
So I
arranged, the non-branching. Yeah, they could be any length, but the diameter, and we'll have the next slide showing a diameter.
And they're extracellular, right?
Yep.
Extracellular, non-branching, without periodicity.
Yeah, so they're supposed to be between like 8 and 15 nanometers.
Mm-hmm.
So yeah, these are between 8.8 to 10.4 is the biggest one.
Yeah. So amyloid average is about 10 nanometers. So.
Oh, 10. Okay.
Okay, good.
Oh, what's your diagnosis, Faraz?
So we've got
pathologic diagnosis.
So we've got AL amyloid, amyloidosis. It's IgA kappa, kappa light chain, AL amyloid.
Great. So before we, Bill's got some slides he wants to go over, but Dr. Gashty, you are our local onconephrologist. Do you have any comments?
So very impressive. I mean, this at this point, usually when we find AL amyloidosis, we attribute this to essentially the primary disease, which is a hematological malignancy. So at this point, this gets back to hematology, and they have to treat the myeloma, the underlying myeloma, as part of the treatment of this. For, we could do some symptomatic stuff, but the underlying disease has to be treated by hematology as multiple myeloma. So I don't have much to add beyond that.
I mean, it's probably a matter of semantics, but to me, myeloma still means you've got collection of myeloma cells and lytic lesions and the like. And I guess it's the difference between calling it myeloma and a plasma cell dyscrasia, but it is a matter of semantics. I mean, the idea here is that you've got a plasma cell clone that's producing this that is not necessarily building up in little pockets and cells causing bone lesions. I mean, Dr. Classic did bring up the point of the hip pain, and I don't know if that's been followed up on, but I think Dr. Whittier will probably let us know maybe some follow-up when we get to that. But I don't personally call this myeloma, but I think, again, it's a matter of semantics. I would say this is primary amyloid, but it's kind of like a Venn diagram. You've got a plasma cell dyscrasia. Sometimes it just gives you cast nephropathy, and sometimes it gives you with lytic lesions and hypercalcemia and the like, and sometimes it just gives you deposition, and it's unclear why there's all these different phenotypes for these, these dyscrasias, light chain deposition disease being a whole other one. And then there's that, 20 other ones that are associated with monoclonal gammopathies. But
well, if we do a bone marrow biopsy and this may end up being a myeloma. So I think this is not, we're not done with the workup. This, again, this goes back into the hand of hematology, but at this point you can call it a plasma cell dyscrasia because it may not need criteria for a diagnosis of myeloma, but I think that this patient will probably need a bone marrow biopsy, skeletal survey. You already hit anemia, renal failure. So I think you just need a couple more criteria, and then it will fall under the myeloma.
So just as a question, I mean, does it really matter at the end of the day? I mean, this person's already got a paraproteinemia with an end organ damage. At the end of the day, does it really matter what you call it other than you stage how widespread the disease is? Is it going to change really the therapy unless there's cardiac involvement or something else which might be a factor? in determining whether or not she'd be a candidate for, we'll say, for a bone marrow transplant. But I mean, whether we split it out as being myeloma associated paraprotein disease, or just call it a paraprotein related disease without having enough evidence by bone marrow to call it myeloma, I mean, does it really matter at the end of the day?
I think it does, Steve.
Okay.
The bone marrow examination, I think, is important in order to type the plasma cells and to determine whether they have chromosomal rearrangements, because the nature of the plasma cell in the marrow of these patients determines how they're going to be treated. In today's therapeutic armamentarium, treatment is directed to the nature of the cell. And we need to know that from the bone marrow.
No, I agree that a bone marrow needs to be done. There's no question about that. I guess the question of whether you call it myeloma or not, because they're going to have an isolated clone of abnormal cells no matter what, right?
Yeah, but the point is, Steve, that the nature of the clone, the chromosomal rearrangements, the cell differentiation marker on the plasma cells now is used as a determination of prognosis and selection of therapy by hematologists.
Fair enough.
So, I mean, we as nephrologists don't really care too much about it, but I think how this patient is going to be treated going forward will depend very much on what the bone marrow looks like.
Okay.
I would suspect that it's going to be very abnormal because, as Roger pointed out, she's very anemic and has a very high mean corpuscular volume, which indicates a high probability of bone marrow disease. She has a hemoglobin of 9 and an elevated MCV.
Yep.
Those are signs of bone marrow disease. So, I mean, I think she's going to have, my guess is she's going to have a very abnormal bone marrow.
Great. Let's move on to Dr. Whittier. I think he has some follow-up and some discussion.
Yes, so 2 weeks after the kidney biopsy, the patient underwent a bone marrow biopsy, and I have a picture of that. Yeah, so you can see it's a very hypercellular marrow. For somebody age 67, you'd expect mostly fat, and you could see rare fat droplets, and it's a very hypercellular marrow. And then if we go to next power, I'm sorry, the next image, this is the aspirate smear of the marrow, and you could see plasma cells with the eccentric nucleus and the purple cytoplasm throughout the smear. So this was diagnosed as plasma cell neoplasm involving 40% of the marrow.
40%. Wow.
Yeah.
Yeah, so she had 40%, and the chromosomal cytogenetics are still pending, unfortunately. But because of her severity of plasma cells, hematology elected to go ahead and start her on some therapy to begin with. They did a CAT scan of the hip, and there was no pathologic fracture there, although I was pretty convinced that that's what it was going to be. And they did a echo with no evidence of any cardiac involvement, as well as an MRA, and then the bone scan was also negative. So she really just she may have had a questionable neuropathy as well, but that was hard to tell from her hip pain causing some nerve damage there or not. So she really, they started her off on daratumumab and Cyborg D, and they're going to try and control that. And if she's still enough of a functional candidate without, depending on her frailty status, then they'll be offering her an autologous stem cell transplant within the next 6 months or so, depending on her response and also how frail she is. So, with that, there were several parts to the case that I think were really interesting and point towards that. When we first got her, it was on a Thursday, and all I knew was hip pain and naproxen for 3 weeks. And so I was pretty convinced it was going to be a nephrotic syndrome for minimal change when I saw her. And then we did the whole workup and got the biopsy all set up for Monday. And by that time on Monday, the IgA kappa came back. and then our differential kind of switched gears a little. And so everyone really discussed that so well. When you get somebody who has, Congo red positivity, like we saw in the case, there's a sort of a standard workup the nephrologist thinks of. And then when you see this at first, the first thing that we're thinking of is it related to a light chain? And so what we do is the immunofluorescence, and that'll tell us if there's kappa or lambda light chain restriction. Lambda obviously goes along more with amyloid than kappa. But if the light chain restriction is negative, the next step we do is the serum amyloid A immunostain to look for a secondary amyloid that you would see in chronic inflammatory conditions. If that ends up being negative is when we sort of send them off for mass spec. And this recently came out in 2020, which was an enormous amount of samples for over 10 years that had gone to the Mayo Clinic for basically, and they send all of their amyloid samples for mass spec. So we typically don't send it for mass spec if it has light chain restriction, and we don't send it if they have a positive serum amyloid immunostain. I'm sorry, a serum A immunostain. But if it's negative for those, then we send it off. And in these enormous amount of samples, they had, here's their percentage of all the different types of amyloids they had. So AL amyloid made up 60% almost, and then transthyretin was 28%. So this was all biopsies. It wasn't just kidney, because we think about transthyretin more with cardiac involvement. And then you got down to more, 3% of ALAC2, and their secondary amyloids were only at 2.8%. But so when you really think about the kidney involvement, if we take out this almost 30% here, almost all of ours can be determined, just like David said, without mass spec. But it is when you have the negative immunofluorescence and negative secondary ones that we need to send for mass spec. And that's when you can see this whole host of them that are possible causes, some hereditary, ALAC2 being the most common cause of the non-primary and secondary. And then this last slide that I have is really because in our case, we did have the immunofluorescence that was positive. We had the light chain restriction, and oddly enough, it was kappa. And we have classically in our biopsy conference quoted about a 30 to 60% kappa to lambda ratio when you're discussing it with amyloid. But I went back and found this large cohort of 230 Chinese patients and who all had AL amyloid. And oddly enough, or the percentages were actually even more disparate compared to what I had thought. Lambda was 86% of the cases compared to 14% being kappa. And there were a couple clinical differences between those kappa and lambda presentations. Kappa had worse nephrotic syndrome at presentation, worse proteinuria, and also a higher serum creatinine. And all of those were significant except for the albumin. They also had a higher mortality, but this wasn't statistically significant. But there was a trend towards a higher mortality. Now, that might have just been related to the fact that they had more severe renal disease at presentation. When they did a multivariate analysis, that they did link mortality to reduced GFR, hypotension, and also the extent of other organ involvement, including cardiac and liver. So now I think when, in the older days, it was melphalan and prednisone, and that was kind of all we gave. But now when we have accurate tissue typing and more targeted therapies, the mortality of this disease is actually improved. And so hopefully, even though that our case presentation was of kappa, she had a couple other things that were really going for her, which was she did not have renal insufficiency yet. She really didn't have any other organ involvement yet. So I'm hopeful that even though she is one of the more rare kappas, I'm hopeful that she'll have a good response.
So what did she get?
So right now she's on, they call it Daracibor-D, which is daratumumab, Cytoxan, and then Velcade with dexamethasone. And they're going to try and have that calm her down a little bit. And then hopefully she'll be able to get an autologous stem cells transplant, again, depending on her frailty status in about 6 months.
I know that in the past, they've been very, very careful about who they transplant based on extra, organ involvement. Steve brought up cardiac disease and the like. I think they're moving away from that a little bit. I think there's some data out of Mayo where patients, even with some cardiac involvement, they will still transplant. Do you know about that, Bill?
Yeah, and fortunately for her echo and MRI were negative, but yeah, I think that they are transplanting some now, even though there's cardiac involvement.
I mean, the issue has to do with prognosis, right? I mean, that's generally what they kind of nail it down to. And I know the Mayo's, I'm sure they update their data every year, I think. But you know, the more organs involved, kind of the worse the prognosis really is what I think what the issue was, as opposed to whether they would do it or they wouldn't. I know at one point, if they had significant cardiac involvement, and I forget what the ejection fraction was, you know, they generally wouldn't do it. But I don't have any doubt if they catch them early, even with cardiac involvement, there may be an advantage. It's too bad, you know, in Europe, and you know, I've never seen it here, but in the UK, they have this serum amyloid P nuclear medicine evaluation that they do that's radio labeled. Since serum amyloid P protein is, since that protein is in all amyloid, you can actually determine by nuclear medicine kind of the extent of the amyloid involved throughout the body. I've not seen that ever here. It's always, I think, the woman, Helen Hawkins, I forget her name, that publishes most of this from the UK. And there are a number of articles that I've seen in AJKD and elsewhere, where it's really pretty cool because you can actually then get a sense of how widespread and how intense the amyloid is. And with treatment, they would actually show that the intensity of these deposits would go away. I don't know how, you know, like I said, this seems to be unique to the UK. I don't know if Dr. Glassick's seen it anywhere else, but it came out years ago, and I thought it was such a cool way of looking at it, but it just kind of died.
It's never been approved by the FDA.
There you have it. Not enough people have amyloid to approve it.
I always find it fascinating how much, you know, disease we see in this kidney with very nephrotic syndrome, yet maybe early enough we don't have renal failure, but no obvious extra renal involvement. And, you know, we've had patients with cardiac and hepatic and capillary with you know, black eyes and skin lesions and big tongue, and you know, she has none of that. And maybe again it's just early, which is maybe good prognostically for her.
Well, the raccoon eyes is usually with sigmoidoscopies. I think when they would put them on a tilt table, and with the increased pressure, then they would develop the so-called raccoon eyes, if you will.
Yeah, it's PPPP, post-proctoscopic periorbital purpura.
Yeah, exactly.
And, a couple of things would be involved there. It was the old rigid sigmoscope. So you'd be in Trendelenburg with your, you know, your derriere way up in the air, and then they'd use a rigid sigmoidoscope, and you'd be valsalving, and you get done with it, and you'd have two black eyes, and that used to be kind of felt to be pathognomonic for amyloid. But
I had a quick question. Bill, it was interesting that with the kappa and the lambda amyloids had different degrees of proteinuria. So kappa is about 22 kilodaltons, and lambda is almost twice the size of that. Do you think the reason you're finding different levels of proteinuria is due to just the amount that these light chains are filtered?
Yeah, you know what? I noticed that too, because there was a slight, I don't know if we can go back to that slide or not, but even if we can't, there was no difference in serum albumin between them, but they were all 2.6, but there was more, a higher degree of proteinuria here. So it's very likely that it's just kappa being filtered more, because they didn't split it out as albuminuria versus total proteinuria. Okay. I think that makes a very good case for that.
you know, there's if you go back to the protocol, there was a pretty big gamma gap too, which you know, Dr. Rubin almost always brings up in these cases. So you know, like I said, there's a lot of things that might not have gone for this, but there you go. It being kappa, and I didn't realize that kappa was that low. I mean, at least that's a pretty big series from China. That it was, you know, 20% or something.
14% versus 86. I was always surprised by that. I always thought it was 60-30.
Yeah, I didn't, you know, I knew there was predominance, but I had no idea it was that low. And that's, like I said, that's 231 patients. That's you're going to find a much bigger collection than that. Maybe at the Mayo Clinic, where they see so many of these. But so prognosis, Bill, what do you think? How do you think? What do you think?
Well, you know, based on this, the mortality really, like we said, was reduced. You know, when you have renal insufficiency presentation, multiple organ involvement, you know, frailty status, all those things go into it. She was a little frail, but most of that was from her hip issues, and she was still working full time, and other than that, pretty active. So I'm hoping she actually has, even though she was so nephrotic, hopefully she has a good prognosis. Interestingly, over the next 2 months, her serum albumin did get down to 0.8. and she actually did develop a DVT, and she was put on enoxaparin.
So you didn't anticoagulate her prophylactically?
I didn't. By the time she was still above 2 when we did the biopsy, and then a month and a half later, she was in the hematologist's office with more leg swelling on a unilateral side, and that's when they diagnosed a DVT. Then it all happened pretty quickly, and her albumin dropped very quickly, almost similar to minimal change. I haven't repeated her cholesterol, but that's something I'm very interested to do now. Although,
did they do a bone survey on her? I know you said they looked at her hip in particular, and you may have said this. I just didn't catch it.
It was negative. That's right.
Negative.
So this used to be a death sentence, and things have really, I mean, as was myeloma for that matter. But with the proteasome inhibitors, and that's there's probably other things now, but it's a whole new game. And I've had several patients that have had AL amyloid and go into remission, get a bone marrow transplant, and they're good 5 years out doing well. So it's kind of remarkable, and I suspect the future is only going to get better in that regard. Before we wrap it up, Dr. Glassick, you have any final points you'd like to make?
No, I'm intrigued by the cholesterol abnormalities in this case. I would love to see a serum PSCK9 in this patient. Be very fascinating.
Yeah, well, we had up to 58 people. Hopefully someone can take that on as a project, because I think it's a great idea. If it's something measurable and compare the different nephrotic syndromes and correlate that with the cholesterol and the proteinuria, I think it'd be a really, really easy study to do. And I think it'd be very, very interesting to find the results. Well, thanks everybody. Appreciate everybody coming today. Remember to go to YouTube and join our channel. We set a new record at 58 today. It's very exciting. And thanks everybody for contributing. Thanks Dr. Baxi for putting these all together. It's a lot of work, his video editing. We will be off next week. We will be back on February 7th at 10 a.m. through GlomCon.
Sunday morning. Sunday morning in the United States.
Exactly.
I believe it's Super Bowl Sunday too.
Oh, wow. Well, it'll be Super Biopsy and Super Bowl in one day. Everybody stay safe, and we'll see you in a couple of weeks.